Saurabh, we can start.
So shall we start, Saurabh?
Yeah, yes, it's my screen.
Yes,
Okay.
sir.
Yeah, perfect.
That's right. Okay.
So good evening all, and welcome to the National Symposia on changing paradigm in the management of type 2 diabetes and the role of triple drug fixed dose combination, remogliflozin, metformin, and vildagliptin. So I am Dr. Kiran Khalatkar. I am working as a medical advisor at Glenmark. And I extend a warm welcome to all the participants, delegates, our eminent speaker, and my team, my colleague at Glenmark. So as all of you are aware that Glenmark has always been a leader in working towards the improvement of patient healthcare, as well as providing the support to the doctors, healthcare professionals, through various academic events like CMEs, webinars, and symposia. So today's National Symposia is on the background that Glenmark has received DCGI approval for first time, one of its kind, a triple drug fixed dose combination, that is remogliflozin, metformin, and vildagliptin. So as to have a better understanding about this triple drug fixed dose combination from the clinician's perspective, we are glad to have with us Dr. Tirthankar Chaudhary, sir. So we welcome you, sir, for this today's National Symposia event. There is no need to introduce sir, but I take this opportunity to introduce sir in a brief. Sir is a senior consultant diabetes at the Department of Diabetes and Endocrinology at Apollo Multispecialty Hospital, Kolkata. Sir is currently a president at Calcutta Diabetes Endocrinology Forum. Sir has been a principal investigator in international phase 3 studies. Just to name a few: leader, devote, sustain, discovery, pioneer, step 2, focus soul, pioneer plus. Sir has also been a member editorial board of International Journal of Diabetes and Metabolism, reviewer of various journals like British Medical Journal of Diabetes Research and Care, Diabetic Medicinal Journal, Indian Journal of Dermatology. Also, sir has been awarded with the Certificate of Distinction for the Medical Education and Patient Care by Public Health Foundation of India, PHFI India, New Delhi. Sir has also been awarded with a certificate from Distinguished Work in Medical Education and Patient Care by Kolkata Municipal Corporation, Calcutta. And sir also has many publications in various national and international peer-reviewed journals. So with this brief introduction, and without further much ado, I would like to request sir to kindly guide us on this unique triple drug fixed dose combination.
So thank you very much. I thank you very much for your kind introduction. And I think we have got a very interesting topic today. There is undoubtedly, it is not because I'm to tell because the organizers are here, but I do think that simplicity of regimen is always underestimated. And I always say that you can never go, the hashtag is you can never go wrong if you are using a combination of SGLT2 inhibitor and incretin enhancer as a second line to metformin. I always wanted them to come together, and I congratulate Glenmark for bringing this triple combination. And many of you might be thinking that, is this triple combination PKPD wise or otherwise possible? For your information, let me tell you that FDA has just approved the same triple combination. I think Tizadi, I'm not sure. So they've already done it, and we have been doing it. There are international preparations like Triplexion. They have got a triple combination. Even when I was in UK and practicing, I know that we are very, very scared and skeptic about writing combination. But even then they had combination. but two drug. But I think it makes sense if you can establish the PKPD, which is the work of the manufacturer, if you can establish that this combination works, then I think there's nothing like it. On the other day, in one of the advisories, we were talking about when to use it. My take on that, I've said that again, I'm saying that you have to individualize the patient. There is no sweeping statement like I won't use here, I won't use there. You have to look at the HbA1c of the patient. You have to look at the duration of diabetes of the patient. You have to see what drugs the patient on. And then you know very well that if the patient has got something around 8 to 9 HbA1c, whether it is new onset or a duration of some years, you know that to bring down an 8 and 9, you need a triple drug. If you look at the HbA1c reduction of any of the molecules, they range something between 0.7 to 1.5. So if you want to bring them down and you want to be scientific and reasonable, then you need 3 molecules. Now your worry is about the science of the combination, which I think a company like Glenmark, which is a nationally international company, is bringing that science home. And I fully understand that if they have got the evidence, then it is time to be vocal for local. There is no doubt about it. And being a proud Indian, I'm very happy that Glenmark had been able to bring this combination, because more often than not, in the vast majority, you'd use it. Now the question comes is about CVOTs and all. Now let me tell you, if you are very pedantic, you can wait. But the vast majority would come with diabetes whom you need glycemic control. You will need weight reduction. And more importantly, you don't want hypoglycemia. And more importantly, every diabetic patient is at risk. I'm not saying established cardiovascular disease. So every patient is at risk. Therefore, there is no reason why you cannot have the simplicity of regimen on your prescription. Remember that what you write on a prescription is the evidence of your wisdom. It tells you what you are thinking, to be honest. And in this era of clinical inertia, there is absolutely no reason why you should not handle the glucotoxicity, why you shouldn't handle the possible complications, micro and macrovascular. And if we have got, as I go down the slides, you'll understand that the evidence is very, very bright as they project this molecule to us. And I think it's going to be a very, very useful molecule. Let me go down the slides. Do I need to share slide?
Yes, sir. Yes, sir.
Okay. So, sorry for that. So I go to from the beginning. And okay. So what is the peculiar need in type 2 diabetes? When we are talking of this combination, remember, you have got a metformin, you have got a remogliflozin, which is of course a SGLT2 inhibitor, and you have got an incretin enhancer. Now, the thing is that sometimes we talk about an incretin enhancer and not have gone very deep and remain quite superficial. If you look at the DPP4 expression in our population, they are more than our Caucasian partners. We have got evidence to show that DPP4 level are related to obesity. There is enough paper to show that they are related to obesity. And if you look at their preponderance, then you see the Irish people have got slightly less DPP4. If you look at the Germans and Danish studies, then you realize that as the sugar increases, as the obesity increases, their DPP4 level increases. But 2018 BMJ paper have clearly shown that non-obese type 2 diabetes among the Asians have a more pronounced DPP4 inhibitor. Therefore, the science of the incretin enhancer, the metformin, and the SGLT2 inhibitor is very, very important in our subclass population. Now, what is the peculiar need of our type 2 diabetes management? Most important is that you are starting it 10 years before your Caucasian counterpart. That immediately tells you that you are going to have more complication in the lifetime of the patient. Therefore, it is also telling you that you have to be more aggressive than your counterpart globally to prevent any complication. And I do think that prevention of complication, the onus lies a lot on us. I also think that tight glycemic control, you know the evidence of legacy effect, is very important in the beginning. We also know that less hypoglycemia is very important. We know preservation of beta cell is important. And we, of course, know that weight reduction is very important. So adequate glycemic control, beta cell preservation, ease of economy, and simplicity of regimen. Remember that if you are giving 3 tablets separately, we have got evidence to say that the compliance decreases, and therefore the purpose of your treatment also decreases or is defeated. Therefore, it is diligence towards treatment or adherence is very important. And we can overcome clinical inertia by giving 1 molecule instead of 3. And it will be suitable for a vast majority, but you need to individualize the patient. Now, if you look at the needs in Indian type 2 diabetes management, high HbA1c levels at diagnosis and thereafter. It is very interesting to see that in spite of so many molecules available to us, especially over the last 10 to 15 years, our HbA1c still remains abysmal, still remains far less than our expectation or desirable. And you would be even more interested to know that with the development of so many molecules over the past few years, our effectiveness in glycemic control has actually deteriorated. I'm referring to a diabetic medicine and diabetes care paper. Now it has been seen that if you do the observational study over the last few years, that maybe the Accord study brought in the fear. We are seeing that less aggressive approach toward diabetes and a poorer outcome is seen in literature now, already in the medical literature. And if you look at our literature here, a hospital-based observation, or if you look at the original study in the diab care, if you look at the clinical and biochemical profile, you are hanging around 9.0 to 8.9, in fact, 2% more than our target. I believe this is unacceptable. And if you want to work on it, then what we need to do is increase the diabetes education, both in patient and the clinician, as well as we need to be more proactive. And more importantly, probably we need molecules that can increase adherence to treatment. Simplicity of regimen is underestimated in our prescription. Let me repeat it again. Therefore, we need a molecule that will deliver maximum and will have less number of pills to be given. So you can say that minimum government and maximum governance. That's what triple drug tells you. That if you can punch in the tray, I think that's very important. Real world evidence of glycemic control among patients with type 2 diabetes mellitus in India is the TIDE study. And just to mention you that I am one of the reviewer for BMJ Open Diabetes Research and Care. And you can see here what is happening, that 76% of the patients have a poor glycemic control in the TIDE study, and 35.7% have microvascular complications. I think a lot of responsibility has to be taken by us also, because we have to be equally aggressive in communication and in our treatment and the choice of the molecule, because we already know that by the time a patient is diagnosed with diabetes, he has already lost a huge amount, somebody says 50, 60% of the beta cell function and the incretin effect. So if that is the situation, then you can understand how important it is to combat the glucotoxicity and also to combat the risk factors that will generate micro or macrovascular complication. So I think that this slide is seen many times and you are familiar. And we know where we go wrong. We start with the lifestyle modification. Still, the resistance that is generated by the patient is because of lack of education. What they will think is the moment they have diagnosed with diabetes, they will come and tell you that do I need to take tablets? Because they have a feeling that taking tablet is bad. I tell them that you are anti to something that is going to do you good. Same as life. People who want to do you good, you are anti to them. The same as drugs. These tablets are going to keep you better. And what you are trying to do is basically anti to this tablet. So a good discussion in the first interaction or first consultation will save many minutes in your future interaction. So the conversation you lead in your first interaction with the patient is so important, not only for the good outcome of diabetes and prevention of complication, but also from preventing your patient from go to another door from your door. So it is very important that we understand this clinical inertia needs to be overcome with a single pill, double pill, triple pill, or whatever. As long as your HbA1c is in target, I don't mind. If you tell me, no, I want one pill and two pills. But you should always remember that even if you are talking of one and two pill, you have to keep in mind that whether you are trying to take care of other risk factors like weight, the cardiovascular risk, the renal risk. Now, beyond and off, we have got SGLT2 inhibitors giving you evidence in non-diabetics, both in cardiovascular as well as renal benefit. Therefore, it is important that we understand that what we are trying to do is actually prevent and postpone the complications along with managing diabetes. So early control is known to reduce diabetes-related morbidity and mortality, and doubtedly this has gone through from the UKPDS days to till today. We know that if you can take care of the glycemic thing, then you know that you will have risk reduction of 14% in MI, 43% in peripheral vascular disease, 12% in stroke, and 16% in heart failure. Let me tell you something about the heart failure. I think the data may be slightly primitive in the sense for ischemic or atherosclerotic cardiovascular disease, you have a clear-cut primary and the secondary. But if you look at the heart failure, then you must remember that this is a continuous process. Heart failure in diabetes can be atherosclerotic, ASCVD, or it can be non-ASCVD, a diabetic cardiomyopathy, where even hyperglycemia can bind to your myofibrils and it can have effect on the cardiac muscles and the circulation. And there can be advanced glycated end products. There is, of course, a complex molecular interaction that goes on that can actually cause heart failure as a continuous process much earlier than you anticipate. Also, if you do an echo in patients of diabetes, you'll find a vast number are perfectly all right, but they will have a diastolic dysfunction. If you do NT-proBNP, you will find the biochemical markers are high. That means the patient is already having heart failure with a preserved ejection fraction. Therefore, using an SGLT2 inhibitor along with metformin and a incretin enhancer like DPP4 inhibitors makes so much sense in these patients. Therefore, my suggestion is that we take this very seriously if we want to keep our patient better. Now, if you look at the peculiar needs of diabetes management, then we know that how low adherence rates to therapy. If you take anything from primary to tertiary care, and you see it varies between 30 to 60%, I think that is very worrisome. The prescription that you are giving is so different and so varied that your adherence rate is pretty low. So I think a lot to do with the education as well. Peculiar needs in Indian type 2 diabetes management. As you know, that high clinical usage of multi-drug regimen. I think it is very important that we become proactive in our management rather than reactive. These two terms or words are very important. When you are treating a patient, whether you want to be proactive or you want to be a reactive. What I mean is that when you are proactive, you are giving tablets to prevent complication. And reactive is once the complication occurs, once the blood sugar goes up, once the heart has a problem, once you have got ischemic heart disease, once you have heart failure, once there is albuminuria, then you are reacting to it. Therefore, it is very important that we use multiple drugs because diabetes is a multifactorial disorder, especially type 2. Now, new paradigms in type 2 diabetes management. As we know that if you have got look at the ominous octet, you know very well difference of ominous octet. Basically, we know that, as I was saying, it has got a multiple pathology. We started our medical school knowing that diabetes is a disease of decreased insulin secretion and insulin resistance. I hope many of you who are of my generation would remember that. But then you remember, we realized that it is also a disease of alpha cell disease. So it is not only a beta, it's alpha cell defect. As time went on, we realized there's something called incretin, and it is a GI hormone problem. Then we realized that there is a problem of SGLT2. So we realized that we can do something when in our time, having sugar in the urine was itself an alarming situation. Now we are saying get rid of them. So we realized the pathology in our kidneys. As time went on, we also realized about the glucose transporters, GLUT2, 3, 4, etc. And we realized the endocrine crosstalk between the GI, the liver, the pancreas, the kidneys, even the brain. So now we are talking of the brain and pancreas endocrine crosstalk. Therefore, all of the organs are actively involved in terms of our diabetes pathology. And that is, of course, shown in that nutshell. So if you have multiple pathology, multiple factors, then obviously you need multiple drugs or drugs that attacks the multiple places to prevent the bad outcome of diabetes. So early attainment of target, improved glycemic control, reduced complication, delayed disease progression, and better compliance with FDC are the goals of the multiple benefit that we can think of a combination therapy. Now, let us look at the combination therapy, how they offer multiple benefits. The armamentarium of drugs today open up many possibilities of combination. As we know, that if you are using, if you have got all these molecules and you know the combinations we get, you can have sulfonylurea and metformin, you have got DPP4 and metformin, you have got pioglitazone metformin, you have got sulfonylurea metformin and pioglitazone. There are a lot of combinations that is available in the market. And nowadays, you know, even a GLP-1 array is with a basal insulin. So there's multiple combinations. Now we have to make a rational combination and use it rationally. So we need an effective balanced combination that attacks multiple targets and is effectively chosen the right patient. So individualization of patient has never gone out of our antenna when we are talking. So consideration of drug classes for combination. You should use a combination that are complementary and their combination should not be toxic. Now let us see how we can do that. If you look all the molecules and if you look at the metformin DPP4, this is metformin. And if you look at the DPP4 and look at SGLT2 inhibitor, then you see how they complement each other. This is strong here. This is yellowish. This is moderate. And you can see when it comes to hypoglycemic risk, they all have the benefit. If you come to effect on the body weight, you can see they are all green, how they are adding up. Safety and tolerability, you can see how safe it is. You can see the safety and tolerability. And if you look at cost of therapy, then of course some are expensive. But of course they are trying to bring it down a lot. And the CV benefits. So if you combine this, then if you look at metformin, acts on insulin resistance and hepatic glucose output. If you look at DPP4 incretin-based therapy has a lot of targets, but DPP4 predominantly on the insulin secretion and glucagon inhibition. If you look at SGLT2 inhibitor, then you know the cardio, metabolic, and renal benefit it has got. Being an uricosuric, being a natriuretic, being throwing up glucose and calories causing weight loss, its effect on the now we know that even obstructive sleep apnea, we know of the fatty liver or NAFLD. We know of the atherosclerotic cardiovascular disease and more importantly, and most importantly, the heart failure. Therefore, this combination is going to work. And you can see the others. There are so many red marks when you combine others. So consideration of drug classes of combination. So you should intelligently combine. And the first line is metformin for vast majority, except exceptions where SGLT2 inhibitor takes over in established cardiovascular disease. So if you combine metformin and DPP4, incretin-based therapy and SGLT2 inhibitor, remember SGLT2 inhibitor is the only drug which is insulin-independent mechanism in the body. So it doesn't bother what is your insulin. It doesn't act through insulin. And DPP4 and metformin acts through insulin. Therefore, if you combine them, it's going to be a very, very clever and intelligent combination. So you can see combination therapy, better compliance with FDC, and can we do something with the cost? That is what the mind. And have we got the right PD studies, pharmacokinetics and pharmacodynamics? Do we have side effects? Is there toxicity? My worries are, what is the shelf life? Do they interfere with the shelf life? Do they interfere with the bioavailability, or what we say, PKPD? Do the combination causes any change in the duration of shelf life of the molecule? Because in India, it's a warm country kept in the shelf for a long. So decrease the risk of non-compliance by using FDC versus single pin. So it is very important that if you can give all the three together, and you can improve compliance, but your combination should be intelligent. Over 3 years, FDC versus loose pill offered higher change in adherence. We know that. Higher persistence, that makes reasonable. Smaller change in number of drug prescription. I think I also try to use as much as I can of established evidence-based combination pill. It makes your prescription look very small. Today only I had a patient, and you know what the patient was getting? Patient was getting natural XSR or indapamide. Patient was getting amlodipine 5 milligram, makes sense. And patient was getting an AC inhibitor in full strength. So 3 tablets. What I did, I gave a combination of the 3 in the name of triplex. Here's 1 tablet, all the 3. Same you can do with this. If you can give somebody an SGLT2 inhibitor, DPP4 and metformin, you are doing the same thing. So number of times you are taking less pill in the life of the patient, in the month of the patient, is alarming. And what happens? Each 10% increase in adherence with ADD was associated with the 0.1% HbA1c decrease. Each 10% decrease in adherence was associated with a 0.15% HbA1c increase. So do not underestimate the importance of combination. Expert panel opinion. I was in one of them. Don't know if I was here. So what we found is that fixed dose combination, the panel opined that improve patient adherence, reduce cost, play a crucial role in achieving glycemic targets effectively. Thereby, FTZs play an important role in the management of diabetes. I would have wanted it to be more specific, that across board, this molecule is invaluable. However, understanding the difference between rational and irrational FDC combination is necessary from safety. I think I'll give that job to DCJ and tolerability perspective. So if a company is investing, crores of rupees in making a molecule, and companies which are established in reputation and that are Indian internationals, we have to believe that they must be trying to achieve what we all want to achieve. Because nobody would invest crores of rupees to make a combination that is toxic, a combination that doesn't have a PKPD studies, a combination that doesn't have a shelf life, a combination that doesn't work. Therefore, it is very important that you can ask questions, and I hold manufacturers accountable to answering the questions, but I'm sure that they have got very good answers, as I have found in advisories. So rationale for choosing a fixed dose combination. Drug in combination should have a different mechanism of action. If you're doing same thing twice doesn't help much because diabetes is a multifactorial disease. The pharmacokinetics of the drugs should also be taken into account when you are doing this. The combination should not have additives that can induce supra-additive toxicity. That is, of course, true. The combination can be chosen based on the recommendation of treatment guidelines. So it is also important that it may not be possible for all of you to be abreast with all the things going on in the scientific world, but you should follow guidelines. That gives you at least some idea that where we are. Now you can see that how the combinations have been done. You have got metformin, sulfonylurea, and TZD. I'm not saying you can't use it, but probably is falling into disrepute. So it is, there are many triple drugs available like these in India. And if you are using them cleverly, there is no problem with that. And mechanism of actions, if they are different, then their effect is also additive. So that if you look at the ACE 2020 guidelines, then you know where there's GLT2 inhibitors, the incretin-based therapy and metformin have gone up in our ladder. Therefore, it makes very much sense that if you are using the combination, you will be there. And especially in a group of patients, even if there is an established cardiovascular disease, this combination will be appropriate. I think this is a very good to start with the one molecule. So I'm not saying this is the molecule and you have to stop. What I'm saying this is the molecule that will help you achieve your targets very early. So this is important. And many questions might come. What about genitourinary infection? What are the other things? But I don't think that any of these combinations, if not decreased, have not ever increased any of the, in the studies, the outcome or side effects. So US FDA approval, as I said, is Boehringer has already got it in Trizerdi XR. So they have combined the Empalina and metformin. So no reason why we can't do that as long as we can show evidence in favor. And of course, I'll ask organizers to do some studies and put to FDA, because if we get an FDA approval with some more studies that they are mandatory for them, I think that would be a very nice to know that an Indian molecule floating around in the world. A lot of genetics do that. Holistic management of metformin as SGLT2 Why you are saying holistic? Because if you take this combination, as I was saying, metformin is looking at the hepatic glucose output as well as some amount of insulin resistance. We know that DPP4 is looking at your insulin secretion as well as glucagon suppression, and SGLT2, of course, looking at metabolic, cardio, and renal benefits. Therefore, this combination is very useful, and I think we should look at the holistic approach, cardio, hepatorenal benefit, beta cell preservation. Well, even the DPP4 is more appropriate for our population. As I say, 2018 in BNJ paper has shown you that even in Indians, in non-obese type 2, our DPP4 is more pronounced than, of course, than the Irish. Irish have a low DPP4, but even in patients of German and Danish studies have shown that they keep on increasing with obesity. But in us, you don't have to worry about obesity, that we have got a higher amount of DPP4. So an inhibitor would make sense. So this combination is important in terms of efficacy, safety, and clinical practice. And so you can see a significant and durable to reduce dysglycemic parameter, cardiohepatorenal protective, beta cell preservation. Well, this one definitely in vitro and in animal models, not overlapping toxicities, no increased risk of severe weight gain or hypoglycemia, no drug-drug interaction, oral administration, a very important fact to say. Metformin first-line therapy, cost-effective, and most importantly, simplicity of regimen. So you are our only class of oral anti-diabetes with multiple extraglycemic. We know weight loss, cardiorenal benefit, obesity, blood pressure every year. Sometimes people say, you are showing me a blood pressure decrease of only 5 to 6 mmHg. How does that, because when we take blood pressure in the clinic, somebody takes 130, somebody takes 134. How does it matter? Well, the important message I want to give you, that even 4 to 5 mmHg of systolic BP reduction reduces sympathetic overdrive and therefore protects the heart. Remember, this is a very important message to tell you that even 4 mmHg of systolic reduction reduces sympathetic overdrive. So you can understand how important these are. Cardioprotection, we know about heart failure. I think, and the benefits start from as soon as you start the medicine. That is very, very important. You don't have to wait for a year for the renal benefit, and heart failure benefit is, I think, touching the sky, breaking the roof. So it is very, very important that we appreciate the importance of this molecule. Consistent SGLT2 inhibitor benefit observed in meta-analysis of CVOTs. If you look at many of the Lancet and other papers, academicians have in essence agreed that the class benefit, that these molecules as a class have the benefit. And therefore, major adverse CV event, you can see here, there are so many studies, CV death or heart failure, reduction by 11%, 20%, or renal failure, 45%. I believe that these are very important data to consider. Consistent class effect on CV outcome. I was saying that class effect is very important because all these molecules works the same way. And of course, we know the benefits have been shown. And if you look at the forest scatter, they all come here. Therefore, look at any of the studies, EMPAREG, Canvas, Declare, Credence, Vertis, pooled estimate, all are here. Therefore, I think the class effect of SGLT2 inhibitors on cardiorenal outcome. Meta-analysis of CV safety or DPP4I, I think with the TECOS and all we have got, even we are doing a lot of real-world studies with teneligliptin. So we have got a lot of benefits that we know already. And number of patients, if you look at the heart failure, look at the CV mortality, stroke, I think we are using a safe molecule. Metformin independently has shown some CV benefits. There are claims that it can prevent, it can have some benefit on the complications. Some say weight neutral, some say weight loss, some say some cardiovascular benefit. Recent analysis supports CV benefit of metformin. So there are studies that also, although it is not, probably more studies is needed, and we need a prospective randomized control study to prove. But of course, meta-analysis proves that this has cardiovascular benefit of all causes of cardiovascular mortality in patients with coronary artery disease. That is a systemic review and updated meta-analysis. If you look at recent meta-analysis supports CV safety of metformin, again, you can see so many papers. I think people who think other way around is doing a disservice to the science. So CV mortality and all-cause mortality are definitely slightly in favor of metformin. Past evidence to observe CV benefits with metformin. Diabetic medicine reduced cardiovascular morbidity and mortality associated with metformin used in subjects of type 2 diabetes. So there are papers which are actually mentioned this cardiovascular outcome trials in oral diabetes medication. They have done systematic reviews. Cost effectiveness of DPP4 inhibitor, SGLT2 inhibitor combination therapy for type 2. I think the cost effectiveness is the probably last but not the least, because it is very important that the drug that you are giving every day and the drug that is going to be taken for life almost or for very many years, cost is very important. And I think there this combination by the organizers is a very, very important step forward. So what are the takeaway points? Takeaway points are generic medications, frequently followed by insulin, are commonly used as therapy intensifiers after metformin. But a pathway of newer medication of DPP4, SGLT2 inhibitor, prior to insulin may cost effective over a lifetime. Evaluation of this sequence revealed that it is increased cost compared with the generic pathway, yet also improved quality adjusted life years. I think this is an important statement to make. Costs were partially offset by reduction in diabetes-related complication and delayed insulinization. In the United States, sequential addition of SGLT2 inhibitor and DPP4 may be cost-effective compared with traditional treatment using generic medication for patients not at glycemic goal on metformin. So, CDSCO panel not to market Remo, Vilda, and metformin. As you know, that Vilda is, this combination has got Vilda, and so your chance of objection to this combination is very less. And we have got now FDC of, you can see the phase 3 study named very nicely Forever. So FDC of Remo, Vilda, and for efficacy and reliability. And they did it for Empalina in patients with metformin failure. So 23 sites, good study. And if you look at the combination of Remo and Vilda, as you know that it has gone off patent and it's easy to make. And that has been done here. And there, I think Glenmark is selling it for a long time. So this is the study, and I want to go to the schematic representation. So Remo 100 plus Vilda and metformin continued and EMPA plus Lina. What did they find? They are quite matched in terms of patient inclusion. If you look at glycemic efficacy of HbA1c reduction, then you look, both the molecules is pairing equally with the comparator. I think that is very encouraging. If you look at fasting PG reduction, then the plasma glucose reduction is again matching. Remember, the green is Empalina and blue is Removilda. Therefore, may not be statistically significant, but they are of course non-inferior. Postprandial PG reduction, again, you can see here. So now we have the option, such a brilliant combination of Vilda with Remo and metformin. And I also think that we probably tell the organizer we need some more studies probably with Remo that we can do. I know it's very expensive, but I am still somebody who would say that go for FDA approval with some more studies, both for Tenili and Remo. If you look at body weight reduction, then again you see that they are more or less comparable. Statistically, they are non-inferior. Blood pressure reduction, again, they are comparable. In fact, if you look somewhere number-wise, our molecule is doing better than Empalina. Adverse events, again, you can see they are probably Empalina is this and Removilda. So not much to adverse of interest. Drug-related, nothing. Safety profile, so no increased risk of hypoglycemia. So you have got the main thing, low risk of genital tract infection and genital tract infections. You can see the statistics. And again, I think they are all comparable. So what is the conclusion of Forever study? Triple drug therapy of metformin, Remo, and Vilda was observed to provide early and consistent glycemic reduction, significant extra glycemic effect, weight and BP reduction benefited beyond glycemic control. Triple therapy is not observed to be associated with any additional safety risk or hypoglycemia. All the findings have been found to be comparable to triple drug regimen of metformin and Empalina, which demonstrate non-inferiority in glycemic reduction. So MET, SGLT2 inhibitor, and DPP4 wide clinical benefits. I would say, as I said from the beginning, that there is a vast number of patients that will be candidate to this combination. And if you look at the molecule and their virtues, then you will agree the combination of these three makes sense. Thank you very much. And I'm happy to stop share.
Yeah. So thank you so much, sir, for this wonderful and informative session. So thank you for highlighting various aspects related to fixed dose combination, particularly this triple drug combination, remogliflozin, vildagliptin, and metformin. So now I open this forum for the discussion. And sir, I can see a couple of questions in the chat box. So somebody has asked about how much reduction can we target with this triple drug combination, HbA1c reduction?
I think that's an interesting question. But if you take them separately, you are getting something for a DP4 around 0.7 to 0.9. If you take an SGLT2 inhibitor, again, something sub 1, 0.79. And if you take a metformin, you will also get around 0.9-ish. Now, if you take them and you know very well that how much reduction will happen also depend on baseline. If somebody starts at a higher baseline, then you will have a better benefit. But if you start with a lesser baseline, you will have less benefit. But if you combine them, then obviously you are getting around, say, 2 and slightly more than 2. So 2.1 to 2.5. So if we get a benefit of around 2 roughly, so I think that is what we are seeing in studies, 1.5 to 2. So if we get 2% HbA1c reduction, then also it is very good because you are handling 8% or 8.59%. You give a one dose and you are getting them 6.5. Never forget the lifestyle intervention.
Right.
So what I'm trying to say that if we have got somebody 8.5 coming to you, you'll get the lifestyle on for 0.4 to 0.5% reduction of HbA1c. And then you put this as a 1.5 to 2, depending on patients, as you know. So then also you're getting 2% reduction. So 8 to 8.5% would be. If somebody has got a 10 to 12, somebody will ask me, don't we give this? See, there is a question. If you are getting somebody beyond 10 HbA1c and coming to you, number one to know is the duration of diabetes. Because if you have got early on, they will improve. Second is how they are coming to you. Are they coming to you with osmotic symptoms and weight loss? Or they are asymptomatic acute hyperglycemia? If they're asymptomatic hyperglycemia, even if you have given this molecule and added sulfonylurea, because they are asymptomatic hyperglycemia, and remember the duration, because they have, we also want to know what is the reserve of insulin they have got. But if you have got a symptomatic osmotic symptoms, catabolic symptoms, you should give insulin. There's no doubt about it. So therefore, the point is that you need to individualize the patient at the end of the day. But there is no blanket rule that you cannot give to the newly diagnosed or that you cannot give it to somebody who's diagnosed on 1 or 2 tablets. So we need to individualize.
Right. Perfect, sir. So in continuation to your thought, there is a question in the chat box that what do you think about initiating this triple drug combination in newly diagnosed patients or drug naive patients?
Yeah, I think this is the $1 million question you'd be asking. Now, right. I would say somebody coming with the obese new onset type 2 diabetes, HbA1c 8 and 8.5, I would start this. Why did I say that? Number one, I want to catch the bull by the horn, number one. Second is, if I get an obese patient, a new onset, I want the weight to come down. Number two, even new onset diabetes has a potential complications or risk factors in the patient that you can only address by these two molecules. And remember, these two molecules is almost insignificant in terms of hypoglycemia. So you don't get hypoglycemia, you get HbA1c reduction, and you are trying to address the at-risk patient. So why should you not use? But if you say somebody comes to you with 7 or 7.4, and you want to put lifestyle and DPP4 and metformin, I don't blame you. I leave it to your wisdom. But there is no blanket rule that a new onset diabetes, BMI 30, coming to me, asymptomatic, not catabolic symptoms, 8.5 HbA1c, and family history of diabetes. I start them on this straight and my job is done because a lot of things have been taken care. Of course, I'm not saying that just fill it, shut it, and forget it. I give it, do the necessary education, call him back in 3 to 4 weeks and see where I am. So it is very important that you should keep tracking, and SMBG is also very important at home. Tell them all the risk, but there is nothing called you can't give. So although you know very well, and as much as I do, that we have got patients on metformin and then you would prefer giving this, or patient on maybe Vilda metformin hanging around 7.5 and you want to give this, that we all know. But the point is that you are not going to do anything wrong if you choose your patient appropriately.
Right, sir. Right. Perfect. So there is a question particularly related to the metformin. So what is your opinion regarding long-term intake of metformin and lactic acidosis or ketoacidosis?
I'm I'm in this profession for almost now 25, 30 years. Let me tell you that this was a lot of hype at long back. Now we don't think. But I'm not suggesting you to give it to a septic patient. I don't want you to give you somebody with a frank heart failure. I don't want to give you metformin, but I have not seen it to put it in as a one line. Not seen a lactic acidosis metformin, but I have not given it in septic patient. I have not given in a frank NYHA class 4 heart failure and giving metformin. So I have taken the precautions, but I think that is something you would individualize in a very discreetly, or somebody with a overt renal failure and things like that. I have not. I would not consider that in day-to-day practice as an impediment.
Right, right, sir. So there is one more practical question. Uh, Considering this is a triple drug combination, so would there be a concern of hypoglycemia?
As I said, that if you look at all the molecules individually, the chances of hypoglycemia is very remote. Metformin, if you look at the mechanism of action, it reduces insulin resistance and hepatic glucose output. If you look at SGLT2 inhibitor, it just throws away the urine that the sugar that came into your tubules. If you look at DPP4, it causes slight insulin secretion and glucagon suppression. But DPP4, a lot of studies have been done, and there is glucotropin. Chances of hypoglycemia is very remote. Therefore, I don't think this is something you will. But with our long practice, and sometimes we have seen some patients do come even with DPP4 and claim that my sugar is good. And when we look at it, we find it 75, 78. So, well, chances are very remote, and chances of hypoglycemia are very remote. And especially if you are using at the range I said, A1C 80 or 8.5, I don't think you should come across hypoglycemia for all practical purposes.
Right, sir. Right. Thank you, sir. So there is one more concern again about the GTI and UTI. So would the risk of this GTI, UTI be on a lower side with the usage of this triple drug
See,
combination?
there are evidence to show that if you combine this combination of DPP4 with LGL2 inhibitor, then there are many papers, not one, that have shown lower genital mycotic infection is more common. Urinary tract infection is less common. Although it is there, less common. So if you look at the mycotic infection, I think even in literature it is underwritten than we see in practice. But I think they are claiming it is less, and I also have the feeling that there are less complaints. Another one I want to give you as my tip, that when you are introducing SGLT2 inhibitor in somebody with a very high blood sugar, then you will find the chances of that is more. And sometimes what I do is, especially in female patient, is that I give them a candid V gel and start the whole stuff and say, take it for 2 weeks. By that time, sugar comes down and chances of that also finishes as a prophylactic. I don't know whether there is a science or not, but that it works. And on the other hand, the other thing you can do, somebody have a high sugar, treat with whatever you want. Once the sugar comes down, introduce your SGLT2 inhibitor. And if you want to use all the three together, use all the three, give a candid V gel for 2 weeks, and you have no worries. That's what my experience.
Perfect, perfect, sir. Perfect. Thank you, sir, for clarifying these concerns, GTI, UTI, and even the hypoglycemia. I hope the audience must have got their answers and these doubts clarified. So there are a couple of questions from my end, sir. I would just like to understand from you. So where do you see the place of this triple drug combination in the overall journey of diabetes?
See, I see it on the earlier than later. That is my number one point. I want to see this molecule earlier than later. So it has become almost thing that you metformin, incretin-based therapy, and SGLT2 inhibitor. This is the molecule to go. There is no doubt about it. Therefore, I think in early on in diabetes, you have got a huge potential to use this, and some amount of individualization is needed, because I can't force and tell everybody to start this right at new diagnosis. but there will be huge number of patients on new diagnosis where you can use it. And there will be a lot of patients on metformin where you can start this. There will be a lot of patients on Met and Vilda, and then you will use this. So there's a lot of option to use it. I think you have got a huge market for this in diabetes, because you are addressing multiple complications, potential complications, and multiple points in diabetes with this combination.
Right. Thank you, sir. So just the last question, which is reflecting here on the chat box, that what about the peripheral neuropathy on long-term use of metformin, incidence or dose related?
Well, you and I also know that long-term metformin had issues about this thing. And we nowadays, you and I do, that we try to supplement with some B vitamins in these patients that we treat. There is hardly a patient, yours and mine, lives without maybe a Neurobion Fort or a Neurobion Plus or a Met Neurobion OD or just methicobal and things like that in vast majority. So we take that precaution. In long term, I want you to take that precaution. Not really something that I'll worry about, because the benefits far outweigh the risk. Thank you.
Right. Thank you, sir. I guess there are no more questions in the chat box. So on behalf of Glenmark, sir, we would like to thank you for your for being here and covering all the aspects related to these fixed dose combinations, from the need gap of diabetes, where exactly this triple drug combination can be used, what are the benefits, what are the concerns, how those concerns can be tackled with this triple drug combination. So thank you, sir. Thank you for covering all.
Thank you very much for inviting me. And I think
sir,
it's a very good program.
Yes,
actually, today I had a very busy day. So my throat was playing a part in the beginning. I saw a huge number of patients in the hospital. Then I came back. I was online just before I jumped onto yours. But hopefully I managed. Thank you.
Thank you, sir. Thank you. Thank you so much for sharing your time here from your busy schedule. And just before wrapping up this today's session, would like to have a brief concluding remark from you, sir.
Sorry?
Brief concluding remark.
I'll tell you something, that SGLT2 inhibitors still have many more beneficial issues that will come to light as time goes. This combination, as a concluding remark, is one of the most efficacious, practical drug in our armamentarium. And to tell you the future, I'll tell you that SGLT2 inhibitors have a lot more. Presently, I've been invited to write 4 chapters in an international textbook on metabolic syndrome by Elsevier coming next year, along with the global heavyweights. And we are increasingly, in fact, I included in one chapter about NAFLD and SGLT2 inhibitor to show that. So I think in one slide, you have got a fantastic combination that you need to use it extensively, proactively, not because Glenmark is doing this evening, because you will need it in your practice. That's my bottom line.
Thank you, sir. Thank you so much. And I would like to thank our audience delegates also for their interactive asking few questions and interactions. And thanks to my team here working with me for making this event so successful. Thank you, sir. Thank you so much. And have a great weekend to all of you. Thank you.
Same to you. Thank you very much. Okay. Bye.
Thank you, sir.
Okay.
Yeah.
To introduce for the first time in India a combination of SGLT2 inhibitor, DPP4 inhibitor and metformin, Glenmark Zoltan Care Team launching a match winner combination with 3 match winners in one pill: remogliflozin, metformin and vildagliptin. Remocin MV. 3 match winners, 1 pill.
Dr. Kiran. Dr. Kiran, thank you very much. Thank you very much, team at the back end. Saurav, thank you so much.
Welcome, sir.
Bye.
Thanks, Omkar. Chalo. Thanks, Saurav. Thank you.
Welcome,
Thanks,
sir.
Dr. Kiran. Bye. So 7th is the program. Huh?
Right,
So
right.
this we have highlighted. Yeah.
Yeah.
Bye.
Yeah, bye. Sure. Want to do it?